cilia, right? Okay, so we know what cilia does, and we know that it can cause, well, if there's a problem with cilia, because what does cilia do? It removes, it gets rid of that stuff. So if I've got a smoker, his cilia don't move like that, does it? No. So we can't get rid of all that junk, so that puts our patient at a higher risk for pneumonia. But remember, I think I told you the other day, our patients don't get pneumonia after surgery, do they? No. Because we do this all the time, and we do interventions so they won't get pneumonia. Now, I wish I could say every one of my patients won't get pneumonia, but I know without a shadow of a doubt that you are taking care of a patient who's coming out of surgery, that you're going to do everything that you could possibly can so he doesn't get it, right? Right. Okay, good. That's what I thought. And that's the kind of things we're going to do. One of the biggest things people have trouble with after they've had surgery is turning and coughing and ambulating. Especially if they've had abdominal surgery. They don't want to get up. I can tell you right after I had my hysterectomy and my bladder tack, the next morning the nurse looked at me and said, "Let's get up." I said, "No. Not going to do it." "Yes, you are. You're getting up." I ain't doing it. And at that point in time, I got a little ugly. Said I wasn't getting up. And guess what she did? She got me up, didn't she? She got a little ugly too. Said, "You are getting up." And I'm so glad I did, because I didn't get pneumonia. And so it's one of those things like, I don't feel like getting up, my stomach hurts. You got to whine. You have to have a pity party every now and then. But the explanation that she gave me, even though I wasn't RN, sort of kicked me in the behind and said, "Okay, let's get up. You know what you got to do. Get up and do it." So hopefully you'll be like that too. Okay. Well, wrong way. Isn't this fitting that this just came up? Isn't it wonderful? Because this is going to give me an opportunity to sort of hit some spots that maybe you feel like you didn't get. Okay? Not going into the whole kit and caboodle with diabetes, but at least you can see that with my patients that are diabetic, they got but they've got concerns prior to coming into surgery, right? Because I know without a shadow of a doubt that if they're a diabetic, then what do I immediately think of when a patient that has diabetes that comes in and has surgery? I think about infection. I think about delayed wound healing. I think about hypo and hyper. Now, wait a minute here. I'm just not so understanding why you're saying hyper.
Because stress increases the blood pressure.
Right, that stress response is saying, woohoo! What's really is it saying? You're stressing me out, body, so what does it start doing? Start doing what? Starts releasing glucagon, and then what happens? Sugar starts going crazy. And then, when the sugar starts going crazy, what happens to my favorite word? Decreased perfusion. Why?
Because the tissue is not carrying the oxygen.
Increased osmolarity.
What's in the tissue? What is in the vessels? Sugar. I usually describe increased or hyperglycemia to my clinical group in the way that if you've got a cup, and I don't know if I've told you this or not before, if you've got a cup of sweet tea, okay, and you've got this much sugar in the bottom of it, and you put your straw in it, as soon as you suck on that straw, what's coming up? Sugar. So that straw is full of sugar. Can the tea get through? So the tea would be the oxygen, so you know it's not getting through. So that in turn is going to make me have decreased perfusion. So then in turn my organs are going to start doing what? They're going to start not getting the oxygen they need, and they're going to become hypoxic, right? And the cells will be saying, hello, could you quit giving me all this sugar and give me some O2? So what's going to happen as a nursing intervention for my patient who's had surgery? What are we going to have to do for that patient who is now hyper? We're going to have to what? Give him, what if he's an insulin-dependent diabetic? What might we have to do? If he's an insulin-dependent diabetic, what we're going to have to do? He's already getting insulin a day. Are we going to have to give him more? Because obviously what he was getting to last him all day long ain't working. Because of the disease process and because of the stress of what he's going through, then I need to give him a little bit more help. What insulin do you think you're going to give him? Good. So, that was the little mini explanation of diabetes, but there's so much more, guys, that you got to know about these diabetes and the signs and symptoms of what I need to be looking for. You know the signs and symptoms of hypo, don't you? You know what you need to be looking for. Do you know the signs of hyper? So you know what you need to be looking for. Okay, so you've got to make sure, because if I don't help my patient stabilize and maintain that blood sugar, is his recovery time for surgery going to be good? It is going to be what? Longer. It's going to be longer. He's going to be in the hospital more, so that costs more money for him. And of course, exactly, Candy, the longer he's in the hospital, the more chances that, what are we going to do? We're going to make him sick, ain't we? Okay, so, and then is he going to be able to respond? No. So my diabetics are really, really important when it comes to educating them prior to. Look, I know you get insulin every day, but let me just get you prepared. As you go through your post-op period, we are going to be watching your blood sugar like crazy. In fact, we're probably going to be doing it about 4 times a day, because we want to make sure that if you're high, then we give you something to bring you down, not only for your diabetes control, but for your wounds, because they have delayed healing, and you know that. So there's lots of things that we need to do to let them know as far as how we're going to take care of them. Where am I at? Am I on the right one? Okay, that's that. Oh goodness, renal and liver. What do we think about when we think about renal? Kidneys, right? And what should I think about when, because that's my job of my kidneys, it gets rid of what? Gets rid of the waste, and sometimes it takes with them what? Electrolytes. What electrolyte is really going to bother to make sure that it's, well, potassium. Okay, you know what I'm trying to say, right? Okay, y'all are getting good. You're reading my mind. Okay, I need to know pre-operatively that this is that he's got adequate kidney function, right? Because if I take him into surgery, I'm getting ready to give him a bunch of what? Drugs. And I got to know that kidney is going to go on out, because if it doesn't, he's going to get sicker, and he's going to hang on to that, especially in combination with the liver dysfunction. So don't you think as preoperative nurses that you're going to be looking at those labs? What's the normal range for potassium?
3.5.
Right. Normal range for BUN?
720.
525.
Huh?
It's 525.
Yeah. And that's from Rowan to Northeast. That's one of those things, guys, that stress you out. I know. Because you want the right one. But that's the range, right? Okay. I usually get it to whatever hospital I'm at, I have to use what theirs is. Okay? So I know that I gotta look at my BUN. What about liver?
Less than 35.
So, well, think what labs first? ALT, AST. Okay. Have y'all started learning these values? Yes, you have. Mark said, learn those things. One of the biggest things you also are, what are you going to look for when a patient with renal, if I don't make sure that that I and O is equal, what can we put our patient at risk for? Fluid overload. Exactly, because once you get into surgery and you look in there, you're going to see them doing that fluid heavily. And they're not going to be calculating the little drops like we do. They're giving them lots and lots of fluid. So I've got to make sure I've got good adequate kidney function so I can get rid of that. Medications. We're going to talk lots and lots about medications. Well, let me back this a minute. It is not my choice on what medications that the patient gets prior to surgery. Okay, because I thought I was already in intra-operative. I'm still in pre-op. In the pre-op thing, it is vital that we know what type of medicines that our patients are on prior to. It is not my call as a nurse to let them know what they need to take prior to. That's the anesthesiologist's issue, not problem, but issue. Because if I've got a patient who comes in and they've got blood pressure medications, that may be one that the anesthesiologist says, you know what, you need to take this with just a sip of water before you come in. Okay, because they know that there may be a possibility that he has hypertension problems when he's in the OR. One of the biggest things that I have a hard time with, not blood pressure medicines, I'm good with that, is the insulins. I have a really hard time telling my patient to continue to take that insulin when they've been PO and they're not going to eat and they come in and they have had their morning dosage. So you have got to educate. We have got to be working as a team with the anesthesiologist in the pre-op area and say, this patient is a diabetic. I need you to make sure that you understand what type of diabetic he is and what are your instructions on what he needs to take prior to coming in. Okay? Most of the time what they'll do, and I like this better, is they say, you're NPO after midnight, don't take your insulin in the morning. When you get here, we will do because that patient will be fasting. Is that going to give me a good indication of what's going on? Okay, so I've got a fasting blood sugar. Then they can make the decision on what they need to do prior to him coming to surgery. Plus, we are there. There are treatments. We can do things if we continue to check that blood sugar and see what I can, in other words, I can keep an eye on them. Okay, they will also look at the times that we took it, and when let's say we gave it to them in pre-op, when they go into the OR, that CRNA is checking that blood sugar. And what do you think she's saying? Once she's checked it, what's she doing? She's letting that physician know, hey, I got a blood sugar of 700. Okay? She has given them, that is part of her assessment to know that she's keeping up with that. Okay? So I'm not going to, what I want you to understand in the pre-op time is there's times that we're going to, the anesthesiologist may change their original medications. Okay, so you need to know that it is not your call. They will talk to the anesthesiologist prior to. Now, if you're in a pre-op situation, as a nurse, because they go and meet with the anesthesiologist prior to coming to surgery that morning, so the anesthesiologist can get a history and look at everything. You need to make sure, if you're that pre-op nurse, to write down every medication that they either need to hold or they need to take. And you need to give them strict instructions, make them verbalize back to you, because it's vital, because there's sometimes they can come in and they haven't been given that information and they've taken a medication that they didn't think was going to bother them because the pre-op nurse didn't go through their whole list, and now they took a medication and the surgery's canceled. You know what, one of the main ones that we're having to do that with? The main drug? An anticoagulant. But I'm on an over-the-counter medication that's not, that I didn't tell my nurse. What's everybody taking now besides aspirin? Fish oil. If your patient, that is vital that you talk to them if they're on. I specifically ask the question about fish oil, because that way I give them an example of what I'm talking about when I say over-the-counter herbs or supplements or anything like that. When you go in there and say, hey, you taking anything over the counter? You know, they're not really sure what we're saying here. We need to explain to him, like fish oil, because fish oil is one that I need you not to take when you go to surgery, because it increases, just not as bad, but like Coumadin and aspirin and that. So fish oil is one that you really need to ask. Oh, I just get ahead of myself, don't I? Lord have mercy. So anticoagulants is the one that I don't want them to really take. You also need to look at NSAIDs as well. People sometimes don't think that ibuprofen is going to affect them when they go to surgery. Some patients the night before, they say, oh yeah, I can eat up till 12 o'clock, and they're very anxious, but they don't want to take anything really. They may take 4 ibuprofens before they go to bed because it's going to help them rest. And they don't think about telling me that when they come in the next morning that they had 4 ibuprofens. So in the pre-op area, those are questions that I like to ask. Not just tell me what kind of meds you've had. Yes, I'm going to ask them their meds that they've had and that we've held. But then I go above and beyond that and say, well, what about ibuprofen? Did you take any ibuprofen last night? Or when's the last time you took any ibuprofen? When's the last time you took your fish oil? Because I know that my patient, before they go into surgery, or when they go into surgery, they're already at risk for hemorrhage. So why am I going to have them on something that's going to make it even worse? So I want to make sure that they're not doing that. If they come in and say, yes, I took 4 ibuprofen last night. Okay, well, you know, PT, INR probably needs to be checked before. Surgery may not be canceled, but I can tell you right now, I'm not letting my patient go into the surgery until I know that PT, PTT, and INR is within normal limits. I would much rather bump them back a little bit so I can take the labs, and I don't want a PT, INR, PTT done that was done 2 days ago, because sometimes our pre-op labs are done 24 to 48 hours before they go to surgery. This is not one that I'm going to take that 24-hour. You see what I'm saying? Don't I want to know exactly what's going on now before I send them?
How long does it take to get the results?
Well, I think in the OR they can pretty much say, I need it now. And so they have a little bit more push there to say, I'm not waiting, because then they'll have to bump this surgery's bump, we'll have to bump somebody else. So those are ones that they get up there, and when they say stat, they mean stat. Just like in the ER. It's not going to take them that long. Oh, backwards. Coumadin. I also, that was one that will be included in that. When patient, you understand what Coumadin does, right? You know why patients are usually on Coumadin? Because they're at risk for DVTs, or they may have some atrial fib. Do you know what AFib is? And it's irregular heart rate that just goes like 120. Okay, so this is 120, 140, whatever. Those are ones that I really get a little nervous about taking them off of it, and I have to weigh it out. So if I have a patient who's been on Coumadin, those are ones that I need for him to be off a little bit of time, but he needs to be consulted with the physician in the pre-op time to tell him how to wean himself down. Because that is not one that I can say, don't take. Coumadin is not a drug that you can just go in and say, okay, we'll just take you right off of it right now. It has to be tapered off because of the reason that if that patient is taken off that Coumadin abruptly, especially if he's got AFib, there's a high possibility that he may go into AFib again, throw a clot, have a PE, and die. Okay, so this is the drug that we don't play with.
Now, mom's on Coumadin, and when they got ready to do her surgery, they gave her Lovenox injection for 5 days. What's the difference between?
Lovenox is going to be a more acute situation. Coumadin is like a long-term thing, but Lovenox, even though its properties and its actions are to thin the blood out, don't have the same effects when patients are put in an acute situation. They tolerate it much better, and they're not at risk for bleeding out like they would with Coumadin.
Because I knew that they were both pretty much the same
Yeah.
thing.
Does she have AFib too?
She has DVT.
Yeah. So, yeah, you know she's already at risk right there, so we've got to do something. So let's wean her off of Coumadin and put her something on, because it's going to thin it, but it doesn't have the effect of causing AFib or bleeding out. It's much, yeah, much better. But there again, you got to watch that PT, eye and arm. All right, diuretics. If they're on diuretics, they're usually on diuretics for their blood pressure is about the biggest thing. So, I don't like to take them off of it until I know that their cardiac system's okay. So, this is one that you may see the physician go ahead and say, you need to take this one. Okay, you may go ahead and see them, but remember, it is not my call. The biggest thing that I want you to understand, there I'm flipping it again, the biggest thing that I want you to understand, because it is not your call, is that in a pre-op situation, you need to have consultation with the anesthesiologist to make the decision on which meds to give. You know why these meds are given, so you can see why they need to either be held or they need to be given. Okay, so in this situation. Antihypertensive, we've talked about that. Here I go talking about my fish oil again. So at least y'all, remember fish oil. And so what was really wild is I didn't realize that until my mother had her hysterectomy. And I was being taught by the pre-op nurse. And the pre-op nurse said to me, said to my mother, do you take fish oil? I was like, Mama said, well, yeah, I do. And she's like, well, no, you don't before you go to surgery. So that was just, and so I had her, I said, oh my goodness, I never thought about that. So she educated me to let me know so I can pass it on to y'all, and we could not give our patients fish oil. Temperature. Are you going to take a patient to the OR with a temp?
Yeah.
Because that's telling me that there may be something going on. In other words, they may already have infection. Do I want them going to the OR setting back there with infection? Mm-mm. So it is vital when you take those pre-op vital signs that you truly check this patient's temp. And we'll talk more about what happens to the patients when we get them back inside the OR as far as temperature. Well, maybe I'll just tell you now. Those of you that's been back in the OR, how is it back there as far as temperature? Cold. Very, very cold. And I think we talked about this the other day in the pediatric rooms and that kind of stuff. So if we're cold, what do you think about the patient? Okay. They're cold too. So you need to make sure that that's one of the things that I don't want them going in. I want preoperatively, I want their temperature to be within normal range before I take them into an environment that's cold. Okay, so make sure they're good. There's warm blankets that you can put on them. I know this is another one of my little pet peeves, and I don't know if you think about this, but you know, your patient's got a little blanket on them, and then they say, I'm freezing. And then you go get a blanket and you lay it on top of the other blankets. Take the old blanket back and put the warm blanket on them, and then put the other one on top of that to keep the warmth in. So that is just a little pet peeve of mine, that I want that warmness close to them to make sure that they're not cold. During the pre-op time, there's going to be people in and out throwing the covers everywhere. Be mindful that heinies are hanging out. Don't let your patient's hiney hang out, you know, because we've got the gown and, you know, and all that kind of stuff. Don't expose them more than they have to be exposed. I think that's one of the things that I see in the OR that sort of makes me a little uncomfortable. And then when you actually go into the OR setting, you'll see the patient all laid out in their glory. Be mindful. Even though they don't know that their monkeys are shining, cover them up. Okay? Cover them up. Keep them covered. Don't be letting them. Plus, you also think, I've got to cover them up because the more their skin is exposed, the colder they may get. Okay? Don't let the drapes get wet. You may have to adjust the temperature. The nurse anesthetist, when she puts them to sleep, will monitor the temperature the whole time she's in there. The way they monitor it, can anybody tell me? They got the thing here, but there's another thing that they've got in the OR that they can use to help keep a continuous.
What is it?
There's some in the nose. The catheter. Who said that? All right, who else said it? All right, good. All right, so when you put a catheter in, it has a little green tube, and you give that to the nurse anesthetist, and she plugs it up, and it continuously monitors that temp while the patient's in there. Isn't that awesome? Because that's a good way to know, because and we talked about this the other day, if my patient gets cold, what is that putting him at risk for? Hypothermia, but
Decreased perfusion.
yeah, exactly. Y'all got it now. And decreased perfusion, but let me go a little another way. That's a good one, but if my patient's temp is dropping, what else is going to happen? What other system is going to start trying to compensate? Respiratory, exactly. So what's going to start happening? My what? My respies are going to be high because I'm trying to compensate because I'm cold. Okay, so my body's trying to get me warm and work that way. So, keep my little boogers warm. Okay, other things that I want to, when you're in the pre-op area, one of the biggest things the anesthesiologists are going to ask that patient is, have you had any more surgeries before? I know sometimes when you go to clinical, you're thinking, why do I need to know all these surgeries? It's more vital to know what type of surgeries they've had when they're in the pre-op area, not just to say when they go in and they're looking for the organs and it's not there. That's not the problem. The problem is they're really wanting to know how they reacted to anesthesia. They want to know what type of problems, when you were put to sleep, what kind of problems did you have? I threw up. Ooh. So that tells the nurse anesthetist, this patient threw up a lot when last time she was put to sleep. I'm going to make sure she doesn't do that this time. There's medications that she can give that will make her not, or help her not be nauseated. When I had some of my surgeries, I decided that, or I used to throw up all the time. The first surgery I had when I was 18 years old, they were wheeling me out to discharge me, and I kept saying, I'm going to throw up, I'm going to throw up, I'm going to throw up. Nobody listened. So when they opened those big old doors to wheel me out, what do you think I did? And I just let it rip. I thought, you know what? You can clean it up because you're not listening to me. I wasn't a nurse then. But, listen to me. You clean it up. Ha, ha, ha. I told you if you gave me a basin, we wouldn't be in this situation. But I don't like to throw up. So I chose the next surgery. And that's what I told the anesthesiologist. You're not putting me to sleep. I'm having my hysterectomy. I'm not going to sleep. And I didn't go to sleep. I had an epidural with my hysterectomy and my bladder tag. I'm stupid, ain't I? Just because I don't like to throw up. Now, I will tell y'all a little story. When I was having my surgery, and we'll talk about epidurals in just a little bit, but I was laying there, here, and I don't know if y'all have ever seen how they position patients when they have a hysterectomy. And I work with these people, so my feet's all up and my stuff's, and so I'm just talking to everybody and having them a little good time. Well, he gave me some Versed, and I was like, woo, I'm feeling good now. I said, that's what they put my epidural in, so I'm going crazy. So all of a sudden, I started feeling a little nauseated, and that was my biggest fear because I didn't want to throw up with my feet hanging up in the air and me laying like this. I thought, oh, God. So I looked at my nurse anesthetist and I said, I'm getting sick on my stomach, and what was happening is that he was right at my cervix. And so with him being in my cervix, and I don't know, all you women, when you've had your pap smear, when they get to that cervix, you sort of feel that not so fresh feeling. So I said, okay, give me some droperidol. I'm getting in orders while I'm laying there. So droperidol is one of the best meds that you could ever give anybody. And I want y'all always to remember that drug for nausea and vomiting. Droperidol. It's on the list. Droperidol. It's on there somewhere, but it is absolutely amazing. So I'm laying there, all spread eagle, and I hear them say, what'd y'all do to her? And I'm thinking, oh God, I'm dying. I'm laying here and I could hear everything that was going on. I just couldn't respond. So I'm laying here and they were going, is she okay? Are you sure she's okay? I'm like, what in the No, and so I'm thinking, okay, they're all just over here just talking junk about me. What are they saying? Well, I heard somebody say, what's wrong with her? She's never quiet. Okay, who hit her in the head with a hammer? I thought if I could kick one of them with my legs, I would. But I heard them talking about me never being quiet, and that I was finally quiet because the droperidol sort of knocked me out a little bit. But I was still talking, and when I woke up, it's like they were like, she's never quiet. Who hit her? So anyway, that was funny. Okay. All right. Allergies is another thing that we've got to look for. You have got to see and ask that patient if they're allergic to shellfish. Okay? Because if they're allergic to shellfish, they may also be allergic to iodine. Okay? So you need to know that when you ask your patients about allergies. Sometimes they don't think, if they have an allergy to shellfish, they're going to tell you because it made them feel awful when they had it. Okay? I even ask them that question, do you have any allergies? And they say, no, I don't have it. Not even to any type of fish, like shellfish, like crabs, anything like that, because they may not have that association that they're allergic to it. Another thing I've learned while being in the OR, this is not in your book, it's just one of the things that some of the OR people told me is if you ask anybody if they're allergic to bananas, they may also have an allergy to latex. So that is like, I've never seen anybody allergic to bananas. Anybody allergic to bananas? You're allergic to bananas? Yep. We're gonna have to really, when she goes to surgery, we're gonna really have to watch her because we do not want her. We're gonna have to have that little tackle box for latex, but I never associated bananas with latex. So that's something, you've learned something today. All right, this is another thing that is very, very common in the pre-op time is you know that patients know that they're at increased risk for losing blood, right? So most surgeries that are, we don't just say, okay, I want to have surgery tomorrow. Some are emergency, and we can't do that in an emergency situation. We can't come up and say, oh, I want to donate some blood for the surgery I'm getting ready to happen. You can't do that. But there are some surgeries, especially like knees and hips, bone surgeries, because 8 times out of 10, when you see a knee replacement or a hip replacement, it's not just because the patient decided, or fail or something. They knew that they were going to have surgery eventually. They have been to the doctor, they may have scoped them already, they've seen, you got a tear. And so that's not an emergent surgery, is it? But we know that it's going to happen. So those type of patients can donate their own blood while they're waiting on the time for them to go to the hospital. Because people get nervous when they think about getting blood. Although it's tested very, very well, they still have a fear of getting a blood transfusion. They do. So if they know they're getting their own blood back, then that's not as scary for them. But there's certain criteria that have to be met prior to them donating their blood. In other words, it can't be 5 weeks close to their surgery. Okay, it needs to be a little bit, books say different things, 5 weeks, 6 weeks. I want them to, because it's going to take them a little time to do what? Make more blood cells and build that volume up. I don't want them already deficit going into the surgery. So up to 5 weeks before that, we can do that. When they donate it, they have to be afebrile, and they have to make sure that their hemoglobin is at least 11 or greater. Hemoglobin. What's the normal range for hemoglobin?
10.
12 to 18. 16. Is that it? It has to be at least 11 before they'll do it. Because if he's already at 8, I don't want to take any more volume. I need to be giving him some volume. Okay? So there's certain criteria that they have to make. It's called autologous. Autologous. So that means that they are donating their own blood. So as a pre-op nurse, it's going to have that they have donated their own blood. It is your responsibility to call the blood bank and make sure that their blood is there in case they need it. Don't make these patients, that they've donated their blood and they're thinking that they're going to get their own blood, and you forget to check as a pre-op nurse that blood's not here. Oh, we sent that one to the other site. You need to make sure it's on the site that they are at. So, and there's a lot of times I reassure after I've checked that their blood's there. I reassure them, if you need blood, your blood's here. I've made sure that it's on site and we can get it just as soon as we need it. Okay, so it's reassuring to them. Can't donate within 72 hours. What is another lab value that you see them doing for a patient who's going to surgery? Which is called type and crossmatch. Exactly. Why is that important? When you give somebody blood, you've got to type and crossmatch to make sure they've got the same blood type, because I don't want to give somebody who's positive, what do I want to give them? I don't want to give them negative, but I can give them O negative, because O negative is what? Universal. What if I have somebody who's negative? Can I give them a positive? No, I cannot. So I can give somebody O negative that's positive, but I can't give somebody O negative positive. That makes sense? I can give O negative to anybody. Okay? But if I have somebody positive, I can't give. It is confusing. Somebody's positive can have negative, O negative. Negative can only have negative. In other words, if I'm O negative, you can't give me A positive.
There's a universal
Okay?
one.
Right. So if you're negative, you need to have negative blood. I like going there. I'm always wanting to go to the OB. All right, you've got to make sure that it is compatible. Oh, wrong way. I just said that. There are also surgeries that we are trying, patients you see patients that they call, for some reason, whether it's religious or medical, they will not receive blood products. What's the major one that will not? Jehovah's Witness. So that's why we ask patient what their religious preference is, because there's some that will not.
They do, like the procedure that was before, would they take a blood transfusion if it was their blood?
No,
Okay.
they will not. Oh, wait a minute. No. They will not. Even if it's theirs.
Like if they knew a surgery was coming up.
They will not even take their own, because it is a blood product added to them, and that I don't care if it's theirs. They will not take it, which is very disheartening sometimes, because you have a patient come in who's bleeding to death and they're Jehovah's Witness, and I can't give them any blood. So, but that's their decision. But anyway, so those the people that have those beliefs, we work with them if we know they're going to have to go to surgery, then we call this, or we try to say, the bloodless surgery. Not that just because they're going to surgery they're not going to lose blood. It's the fact that we minimize the amount of blood sampling that we get from them. Sometimes we just do blood samples, but on people that we know that's going to surgery, we limit the amount of times that we take that 10 cc's out and that 10 cc's out and that 10 cc's out to get their blood. We also can give them a medication that's called Procrit or Epigen. Those are the types of medications that you give cancer patients that help do what? What do you think they do? They help build red blood cells, because cancer patients don't have a good red blood cell count, so it helps build them. So we give that to them. The bad thing about this is it's very expensive. One injection of Procrit or Epigen is $3,000. Very, very expensive. Right. Yeah. I'm not really sure. I probably would have to look that up. I don't know if it works as good as Procrit or Epigen. Let me look that up and see if that would be a choice. Why did you tell the patient? Cancer patient or? And I'm wondering if it's because he had kidney problems as opposed to why they didn't use it. Or finance. I don't know. I'll have to look that up. Just keep reminding me, because you know I have a short-term memory sometimes. Sometimes I have short-term memory. All right, so bloodless, we can also not just give them injections because they are so expensive. Is we can encourage them to take vitamin B. We can give them vitamin B injections because that will help stimulate red blood cells as well. Iron, we can give them. But most of the time, when you give somebody iron, how much do you think you give them? Like 325?
Yeah,
about 325.
Yeah, 325 is about what you get. We're talking about 5 or 6 a day, not just one. And what's the biggest complaint about constipation? And then their stool is black. And so, especially in an older patient, they're going to be really worried about their bowels, especially if I give them, 4, 5, 6 iron pills a day. Yeah, they're not going to like that. So, we will definitely, if we have that much of iron that we give them, we need to be putting them on not a stool softener 1 time a day, but they may need 2 times a day along with some mag. Okay, they can give them or some dynamite, whatever. We might need to get some dynamite. I went backwards. All right, where am I? Oh, I'm going backwards. Help me. All right, discharge planning. All clients we begin discharge planning as soon as we meet them, don't we?
Correct.
If I have a patient who has an orthopedic surgery, don't I need to be making sure that, they may go to a rehab for a couple days, but I also need to start putting in the patient's family's head, do you have a lot of rugs around? If you do, get them up now. Okay? What about steps? Exactly. They may need a ramp put in, so it gives them a little bit of time to know up front, I need to start making these arrangements. All right. Labs, we've talked about labs before. How many times did I talk about them? I have listed every lab value and the reason why that you do the lab values, and put you a little note, need to start learning the ranges. Because I can tell you on this test and tests coming up after this one, you're going to be given the situation where it's going to give you a lab value, and you got to know, is it within normal range? Or is it okay? Or is it too high? Or is it too low? Now, what did I tell y'all about? If there's a range that I want you to look at,
It would be
it's going to be what?
way off.
Crazy out of whack. Exactly. Crazy out of whack. So you know the normal range. You know that it was crazy out of whack or not. The other thing that you'll see them do is pregnancy test on all women of childbearing age. I don't care if you come in and say, I don't have sex. You're getting a pregnancy test. Because what do you think? She just lied to me. Sorry. I don't have sex either sometimes, but. Now, I used to joke around and I'd say, when I'd go to my surgeries after my hysterectomy and stuff, and they'd say, well, I need to do a pregnancy test on it. I said, well, if I'm pregnant, I'm going to be one rich little woman because there is no uterus in here to get pregnant with. So, everybody that is of childbearing, even though they tell me I'm not having intercourse, you will get one. Oh, I can't figure this thing out. Chest x-ray. Don't need to say much about that, do I? Alright, I've got my nursing diagnoses. The major nursing diagnosis is knowledge deficit when you go to surgery, preoperative. My goal is to make sure that they're mentally and physically prepared, and we start their discharge planning. Lord mercy, did I just keep going on and on and on and on and on? All right. think I went, did I go through some of these? Oh, this is a big one. Of course, you know, I'm going to try to keep going, guys. You're just going to have to bear with me because Miss rumbles. If you got to pee, go pee. But I want to keep going because I want to get through all the way of pre-op. How many more I got? A bunch. Miss Walker just goes on and on and on and on and on, doesn't she?
Oh,
All this pre-op. Okay. All right. This is one thing that really confuses everybody every year I talk about this. Informed consent. Anytime your patient is going to surgery, you have to get them to sign an informed consent, a consent form. What that's saying is that they have been given the instructions and they are informed of all the risk factors, everything that's going on with the surgery, what's going to happen in the surgery. They have been informed of everything. It is your responsibility to make sure that it is signed, that you are a witness to the signature. You are not witnessing, or you are not putting your signature there saying you were the one that gave the information. Okay? That is not what you are signing. You are just signing that your patient is signing it and you are witnessing their signature. Does that make sense? Now, your responsibility with the informed consent is you are going to make sure that that patient does not have any questions about the surgery. You are going to ask them specifically, do you have any questions about what's going to happen after your surgery? Do you have any questions about any risk factors or any risk of the surgery? Have you been told all of your questions answered? Do you feel comfortable in understanding everything about your surgery? You with me? You're not saying, now what if your patient says, I don't understand my anesthesia, that I'm going to get the doctor. I can try, now give me a therapeutic response to my patient before I run go get the doctor.
I can try to help you with that, but if I can't answer them, I will not.
Right. Tell me what kind of questions do you have? It may be something as simple as, am I going to have a tube down my throat? Is that within your scope of telling them? Yes, you're going to have a tube down your throat, so when you wake up, your throat might be scratchy, your throat might hurt. Okay? If it's something to the effect of, I don't understand what organ you're coming out, or you're going to take out. Can you tell them what organ? You can tell them what organ. Okay? But then they start asking you all this stuff, well, how's he going to suture me up and all this kind of stuff. And he gets more in depth about what actually happens in the surgery that is beyond your scope, and you need to call the surgeon in. If there's any question that you can't answer, that you feel like this patient hadn't been told about this surgery, he does not understand. All you do is pick up that phone and say, you know what, Dr. Jones, your Miss so-and-so and so-and-so, all of her questions are not being answered. I've answered them, most of them, but I think she needs more education before I'm going to sign the consent form. And you can do that. Okay? Did I already do that? I talked about Jehovah's Witnesses. That's what I just said, not responsible for giving the detailed information. All right. This comes a little tricky too. If if I have a patient who can't read or write, they can sign it with an X. But when you have them sign it with an X, you have to get another RN to witness the X. Okay, so you have to have 2 RNs to actually witness that signature when it is just an X. The other thing that gets everybody in, that worrisome is an emergency situation. So, and the patient can't, because I just said to you, everybody's got to have a consent form, right? Okay, so my patient's coming in and he is in a life-threatening situation. If I don't get him to surgery, he's going to die. The family has been tried to be notified and we can't get anybody. Okay? At that point, they will not require the consent form signed of that patient. The documentation that goes with them is 2 surgeons come in and they that are 2, let me just say, I don't think it has to be even surgeons, 2 doctors. Let's say I've got Dr. Jones that's assessing the situation. He's called the surgeon. They've decided that they were going to go to surgery. They can't, or surgery is needed. They need to get 2 other doctors to assess the situation. And they say that yes, they're agreeing with it, and the patient needs to go to surgery. So it's not just you come in and see. Now, mind you, guys, the other day they had gunshot wounds coming in. The patients are bleeding profusely and blood's going everywhere. They are not going to sit around and try to find 2 more doctors to sign it. Okay, now that's the real world. But NCLEX world says that you've got to have 2 surgeons that are not associated with it. But I can tell you right now, if I've got gunshot wounds going every which way, you better not waste time in finding 2 more surgeons or 2 more people. You better get me to the OR. Okay? That's Miss Walker speaking, but I'm just telling you, from what your book says, you've got to have 2 more people, but in real life, you're going to be gone. You're going to be going to surgery because you know that patient's going to die if you don't. Yeah. Right? I don't want to die. Not yet anyway. Huh?
They did anyway, didn't
What?
They died.
Yeah, they did. So, but it was pretty wild. But anyway. All right, so what if I can't speak, what if my patient can't speak my language? You have got to get an interpreter. Do not try to do your little Ola with them, okay? And think that they understand what you're telling them to do. You need to get, because that's about my extent of Spanish, is Ola. So I don't want me to be signing my name saying that they understand it. You have got to get an interpreter. And I've seen they're amazing too. So use them. Dang, I just keep going on. Why can't I hush? All right. This is another thing that is a little bit concerning to people. Is once you go, everybody generally is encouraged to have an advanced directive or a living will, right? So when they come into the hospital and they decide to go to surgery, 9 times out of 10, that DNR or if I don't want life support is suspended while they're in surgery. Okay? But if you think about it, there are very few DNRs that go to surgery. Okay? It's more towards the fact if I have a living will and it says I don't want to be intubated. Okay? Because it says if I'm, I don't want to be intubated. When I go to surgery, I'm going to be intubated. So my living will at that point has been suspended because I'm going to surgery and I will be intubated. But if I come out of surgery, they can't get me off the ventilator, then I want my living will to go in place. Take me off. okay? So it comes right back. But when it's in surgery, you're going to be intubated, so it's going to be, but most people, it's going to be active, but most people are not going to go to surgery if they're a DNR.
Now, is there a fine line between when to take them off the vent and when is okay? Like, after surgery, they're on the vent. How long do they give them to get off of it before they're put them on the ground?
They've got to give them a chance to start recovering from the surgery. So it's not like, okay, I get them out of surgery, they're on the ventilator, I get them up to ICU, and no, I'm not going to give them a chance to start weaning me down and see how I'm doing by myself. So I can't give you a 6 to 8 hour kind of thing.
So they'll try to wean you off of it.
They'll try to wean me off and then we'll try to get me off quicker because in my living will says I don't want it. So they'll try to keep me. All right, NPO, we've talked many, many times about NPO. Do you know the reason why you're NPO? Because of aspiration. The other thing, there's a lot of anesthesia people that are getting together and they're saying that it's not causing aspiration like that has been causing aspiration for how many years. So you may hear when you go to the OR them saying to the patients or them saying people that they don't have to be NPO, but for your testing purposes and for NECLEX, you have anesthesia would be, you're not going to be tested on anesthesia. Okay, they're the ones that are totally responsible for putting you to sleep, and they can go through the rules and regulations. But right now, 6 to 8 hours prior to is what we recommend, so they don't. Your responsibility as a pre-op nurse is to ask them if they've had anything to eat before or after midnight. If it is, they tell you they've had something to eat, then your responsibility is to contact the anesthesiologist because he's the one that's going to make the decision if the surgery can go, depending on what the patient had and when. Okay, that is not your call. Your call is just to evaluate it and assess to see what they've had, and then the anesthesiologist will make the call on whether they do. But you know, I want you to understand the reasoning why they're NPO is because I don't want them to aspirate. Okay? We've talked about the medications. Why do I keep going? I ain't going over that again. GI prep. You know, a long time ago we used to give everybody an enema when they came in for surgery. Don't happen anymore. Okay? The only time you're going to see a big GI prep is if the patient's going to have any type of bowel surgery. Now, your book says pelvic, but they've gotten away from that. And usually if there's a pelvic issue, they're not doing the GI prep. That's the real world. Sorry, I'm telling you the real world. You're just not going to see it much with the pelvic. Anything rectal, anal area, yeah, we've got to get all that stuff cleaned out before they go. Skin prep. There are lots and lots and lots of pictures in your book that I want you to look at. And I want you to see how they prep their skin. You know that the reason why they prep their skin is because the skin is the first line of defense against infection. So when they clean it, let's say I'm going to have my belly, surgery through my belly button. They are not just cleaning my belly button. Okay? They're going to be cleaning all this. So you can see the big portions in your book to where they're cleaning. Now, I had a student last year that, bless her little heart, she got so upset because the patient was having a vaginal hysterectomy, and they cleaned her out. And my student felt like that was very invasive and made her feel very uncomfortable because what they were doing with the sponge was going like this. So it was really making her feel a little uncomfortable at that little moment. But I tried to explain to her the importance of making sure, because that area is not always cleaned like that, right? You know, I don't know many women that take a soap and water and go all the way up and clean. If y'all do that, and if I'm supposed to do that, will y'all let me know? So it's not an area that we clean like that. So I have to explain to you, that's an area that can be dirty. What are y'all saying? I'm just trying to be honest. I mean, okay. So anyway, she was cleaning that out, and it was really bothering her. So don't stress about that. We've got to get them clean. Okay. All right. After they are scrubbed, you will see them put sterile towels on them. That doesn't mean that they're sterile. They're just putting the sterile towels on them to keep it as clean as possible, because they don't want to put just a regular old towel on there. So they'll keep it as clean as they can. That's the page number 255 in Iggy that has all those on. Big discussion about shaving. We are not shaving the skin with straight razors anymore. They're using electric razors. They are also minimizing the areas that are shaved. Because what happens is when we shave them, it digs the skin. There's a chance for bacteria to get in there, and it becomes a major area of infection. Tubes. When you're in the pre-op area, you need to prepare your patient for the different types of tubes that they're going to be having. For instance, if they and I'm going to bring a tube with me on Thursday. Some of the tubes that we have, and I'll show you how they work. But it's very upsetting if they don't know that there's going to be something coming out of their body when they wake up, like a Foley or something that's in there that's draining blood out. So it's very important that you tell them that prior to them getting medicine, so they won't be alarmed. Does that mean that you're not going to have to tell them again? No, because you probably will. But make sure that they know what all kinds of things that are going in their body. Okay, I'm going backwards. Okay, going backwards. Okay, going backwards. Okay. Y'all know that. All right. Teaching. Post-op teaching. We're going to talk more and more about this, but I don't think I could possibly tell you enough about deep breathing. Do you think I have told you enough about deep breathing, turning, what, for our patient? We're going to teach them prior to, right? Mm-hmm. And we're going to have to teach them after. Incentive spirometer. Do I need to talk about that? This is one thing that I don't think you've heard about. The coughing you've heard, right? I think you've heard enough about me coughing. When patients have incisions, it's very, very uncomfortable for them to really get a good cough. So I want you to teach them how to splint the area. Now, all your books say, get a pillow. Has anybody had abdominal surgery? Is the pillow bulky? Yeah. Pillow's bulky. You know, and NECLET is going to say, get a pillow to splint. Let me tell you in the real world, guys. If you get a blanket or you get a towel and fold it up several times, because even if my incision's from here to here, I can fold that blanket or that towel like this and fit it right here. The point of the matter is I need you to have the patient put the blanket or towel here, put their hands on top of it, and hold themselves and splint that area. A pillow will work. It's very bulky, and I encourage patients to keep that with them at all times, because when they turn, they still. They don't have to splint all the time, but I can tell you right now, if they splint with that little blanket, that's something that's easy for them to keep control over, they will be splinting and they will be moving better. Because of any, with a knee, you ain't gonna be able to do that. It's the abdominal area because the problem is when they go like that, they feel like they're gonna go poop and wide and go right open. Okay, so have them splint themselves, whether it's a pillow. You will also see your open heart patients. They actually make heart pillows for them, and so they put their heart pillow right here. And then they just hug their little heart pillow while they're turning and coughing and deep breathing. So it's a lot of, I just try to make something that's easier for them to control. For me, that was just me, the pillow was getting on my nerves. Everybody knows about TED hose. They will be put on in the OR, okay? Their pulsatile stockings or the compression devices will be put on, and they will come out of surgery with those. And when they get to the post-op area, they will plug them in. Okay, so we start those circulation devices very, very soon. Get them up. Do not let them sit around. Okay, range of motion. We know that about that. Anxiety. So many times we don't look at their anxiety level. So we need to make sure that we're trying to do whatever we can to decrease that. Oh, wrong way. Okay. All right, where am I going? All right. This is about, I think we're close. Yeah. All right. When you are we are still in the pre-op. We ain't made it to the surgery yet. Now, a lot of the things that we talked about, once we get to the post-op, we're not going to have to talk about them again because we've already been over them. And it's the same thing that you did teaching. Can you see that teaching is a vital part of this type of situation? When you are pre-op, there are so many things that you have got to make sure that are right before you take them. You will be reviewing that chart. It is the pre-op nurse's responsibility to make sure that every one of the labs are done. They're within normal range, right? Because if it's out of range, then I'm going to have to go ahead and get somebody. It is my responsibility as a pre-op nurse to make sure that the consent form was signed within 24 hours of the surgery. If you come in and you have checked and that has been signed longer than 24 hours, it has to be discarded and another one has to be done. Okay? You have to get rid of it. Identifies the site of the surgery. You will actually be seeing if your patient is getting their right knee operated on. You will see writing all over it, whether it's a big yes here, this is the knee, or don't operate on me on this one. Something to let you know that when you go in, this is the right one that we need to be. I will check as a pre-op nurse. The surgeon comes in, sees the patient preoperatively, and after they have checked with the patient, and we're going to ask that patient 2,021 times, what leg are you getting operated on? They'll be so sick and tired of us saying, what leg? It's the right one. See the big yes. And the doctors sometimes sign it. Because we don't want them going and operating on the wrong extremity. Allergies are important because of shellfish and nanners. I need to know their height and weight. Huh? So the CRNA has that right there, and she can calculate. Report all abnormal lab values. Make sure that the blood's on site. Reports any concerns to the staff and current vital signs. Patient has to have a hospital gown on. We used to take everybody's panties and boxers off, but now we are letting them keep them on if they are operating above the waist. Okay? Now, if I go in there and I see somebody's got dirty breeches, I'm gonna make them take them off. But if they're clean, I'll let them go. But I ain't letting them go into the OR with stanky stains in their breeches. Okay? All right. No jewelry can be on. You need to make sure if there's something they cannot get off, like a wedding ring, then you can tape. It is fine. You need to make sure all fingernail polish is off, dentures are out, any prosthesis. I want to make sure that they pee before they go into the surgery, which makes it bad sometimes for the nurse that's getting ready to put the catheter in because their bladder's empty. And once they put the catheter in, there's nothing wanting to come out. So what would you do in that situation? Y'all don't want to krill thing no more, do you? All right, should be a little bit, but let's say, but he's been NPO. He ain't had anything to drink in 8 hours. And he just went PP'd and he went 460. In the OR.
Bladder scan. Insert a little bit more.
Keep eye on it.
What?
Just put it in there like.
Gravity.
For them.
Elevate the head of the bed. And that'll help the urine come out.
We
don't
can
want to
push
do
on
all
their bellies like
kinds
they did.
Huh?
We can push on their bellies like they did.
Right. Or one of the first things that I do is I always push right here. Once I insert, I start pushing. And if I can't get anything, then I elevate the head of the bed and that gravity will help a lot. When we catheterize a man, where are we going? All the way to the hub, right? We are not stopping until we get it all the way to the hub before we blow up. All right. Am I going backwards? Go backwards. All right. We'll talk more about anesthesia meds. One of the biggest things that I want you, a term that you're not generally going to, or a term that you're going to see, but you may not know what it is, and it is OCTOR. OCTOR. On call to OR. Okay? That is how the physician's going to write if he wants an antibiotic given, and that's generally what is given at that point. He will write on call to OR. So if you're upstairs and you're getting someone ready on a med-surg floor, you're getting somebody ready for OR, he will write on call to OR. So when they call you and say, I'm ready, you go hang the antibiotic. Okay? So that's a term that you might not be familiar with. Once you have given some of the medications, you need to make sure that the side rolls up. Don't get them out of bed, bed in one position, and tell them that drowsiness and a dry mouth is going to be something that they're going to be feeling. Oh, I am going backwards. Now, finally, we can go to the OR.